aspect of treatment, ischemic heart disease and coronary insufficiency syndrome. Everything will be fast. Don't worry. If you have your own problems, you can safely leave the lecture. So there are different classification of ischemic heart disease. For example, here it's old classification, and in connection with the rapid development of cardiology, it became clear that the existing classification has outlived itself, primarily from the practical point of view. Coronary insufficiency syndrome, this abbreviation, this is a pathologist condition characterized by an absolute or relative myocardial blood supply disorder due to damage coronary arteries of the head. Can you hear my presentation? I'm sorry. Yes?
Yes, doctor.
Okay, thanks. An imbalance between the supply of oxygen and myocardial demand, resulting in myocardial ischemia. Ischemic heart disease or chronic heart disease, atherosclerotic lesion or dissolved of coronary artery system, or lesion destroy coronary artery system, leading to the coronary insufficiency and manifested in the form angina, degeneration, necrosis, myocardial sclerosis, as well as their consequences and complications, including sudden death. You know about it. Acute coronary syndrome, it is a term for any group of clinical signs or symptoms. It is suggestive of acute myocardial infarction and or unstable angina. We know that will present STEMI and STEMI myocardial infarction. So here unstable angina, STEMI and STEMI on the pictures. Stable angina we can see excluded. And STEMI occurs due to incomplete occlusion of the vessel. And STEMI is an infarction, myocardial infarction caused by complete occlusion. It's definition of unstable and STEMI and STEMI myocardial infarction. And recommendation of the European recommendation of cardiology, the concept of chronic coronary syndromes is introduced 6 clinical scenarios. There are 6 clinical scenarios, and will include different cases. All of which scenarios are classified of chronic coronary syndromes, but are associated with the risk of future cardiovascular events. Here, present topic localization of left and right coronary artery, it's blood supply of the heart. On the coronarography, we can see which is clinical pictures. It's left and right coronary artery. Risk factors of ischemic heart disease, they are not modifiable, and main modifiable risk factors, non-modifiable male gender, elderly age, family history, it's non-modifiable. And different lifestyle, so name lifestyle modifiable risk factors will include dyslipidemia, arterial hypertension, smoking, diabetes mellitus, and etc. What are the clinical pictures of myocardial infarctions? It's clinic symptoms, and more often I explain for my students that clinical pictures of myocardial infarction same with clinical pictures of pulmonary embolism, and will include intense pain intersternum with a duration of 20 minutes, maybe another, and additional symptoms may include additional, not may include irradiation of pain on the left arm, lower jaw, neck, and etc. shoulder. So treatment of coronary heart disease different, and on all cases you should divide it into conservative and surgical treatment. Surgical treatment may include radical, direct operation, indirect operation. Direct operation is surgical and endovascular, and conservative treatment it's modifiable and risk factors, restriction, and different medicaments. So, consider treatment of stable angina. You know about it. There are nitrates, beta blockers, calcium channel blockers, and another. And the primary goal of the treatment of patient with ischemic disease, acute coronary syndrome, sorry, with the ST elevation is a renewal of blood flow in the infarct-related artery in the first 12 hours, and will include oxygen support, clopidogrel, nitroglycerin, morphine, and I spoke about it, beta blockers, heparin, and another. Sorry. What is it? Thrombolytic therapy. Thrombolytic therapy we may use on any cases. There are contraindication, absolute and relative for the thrombolytic therapy, but you should know that thrombolytic drugs too expensive, and you may use these drugs only on the short time after manifest of disease. Method of myocardial revascularization. They are indirect operation according to Fiske, Weinberg, oxygen cardiopexia, operation according to Sen, transmyocardial laser revascularization, and direct operation, you know, which is often type of operation, surgical, coronary bypass graft, on pump, off pump, minimum invasive, we can speak about it on our lesson. Endarterectomy with sponge graft reconstruction, endarterectomy with bypass, and even head transplantation. And mini-invasive endovascular method of treatment. It's balloon angioplastic, coronary stenting, and percutaneous transminimal coronary angioplastic. As example, what is it? Operation by Fiske, operation of Weinberg. And main, you know, it's GAP, coronary artery bypass graft surgery, off pump, coronary artery bypass grafting, and mini invasive method, percutaneous coronary intervention. I will show for you, I will demonstrate it. Video, sorry. I will start it. I will start it.
Percutaneous coronary.
Colleagues, can you see video?
Yes, doctor.
Yes.
Okay, continue. It's
Coronary intervention, PCI, has several clinical indications, including improving angina in patients with one or more significant, greater than or equal to 70% in severity, coronary artery stenosis, despite optimal medical therapy. Improving cardiovascular outcomes in patients presenting with acute coronary syndromes due to obstructive coronary artery disease, and improving survival in patients with complex coronary artery disease in the setting where surgical revascularization with coronary artery bypass graft surgery is either too high risk or not possible. The indications and potential risks and benefits of the procedure are discussed with the patient, and informed consent is obtained. A focused physical exam, including auscultation of the heart and lungs, visual assessment of the oropharynx, and palpation of the pulses, is performed to assess the patient's risk for receiving conscious sedation. The patient is placed supine on the catheterization table with both groins exposed. Hair is removed with a razor, and the areas are scrubbed and cleaned with a sterile soap solution. Also seen here is the equipment table, which holds all of the equipment necessary to perform diagnostic coronary angiography, including catheters, needles, wires, etc. Following cleaning, the patient is draped with a sterile drape which has two circular holes in the drape to provide exposure of the bilateral femoral areas. In this example, the tubing for the contrast injection system also serves as the tubing for invasive hemodynamic monitoring. This setup is similar to that of a standard injection manifold. The contrast injection system is prepared by attaching all tubes to the power injector and flushing the system with both heparinized saline and IV contrast. The first step in obtaining femoral artery vascular access is to define general landmarks such as the location of the iliac spine, pubic tubercle, and femoral artery pulse through palpation. It is customary to mark the proposed access point with a hemostat and image the groin area using fluoroscopy. The goal is to have the arterial puncture entry site to be located in the lower to mid-third of the femoral head. The objective is to puncture the artery on the anterior surface below the level of the inguinal ligament, which runs between the iliac spine and pubic tubercle. 1% lidocaine is administered at the skin and into the soft tissue around the access site for local anesthesia. A micropuncture technique for vascular access is demonstrated in this video. The artery is palpated with the left fingers, and the artery is stabilized between the fingers. The micropuncture needle is advanced at the predetermined skin puncture site and advanced until the artery is entered and arterial blood is visualized within the needle hub. The needle is stabilized and the microwire is advanced through the needle and into the vessel where it is visualized under fluoroscopy to advance into the distal aorta, thereby verifying that the wire is not entering any accessory vessels branching off of the femoral or iliac arteries. The micropuncture needle is removed over the wire and a microcatheter is advanced through the skin and into the vessel. The dilator and microwire are removed and a standard J-tipped wire is advanced through the microcatheter into the descending aorta. The microcatheter is removed over the J-tipped wire and the standard vascular sheath. Either 4, 5, or 6 French in size is advanced. The sheath dilator is removed and the sheath is flushed with heparinized saline. In this example, a 6 French EBU 3.75 guiding catheter will be used to cannulate the left coronary artery in preparation for PCI. Various anatomic factors such as a lesion location and tortuosity play critical roles in the choice of guide catheter curve. Coronary catheters are always advanced over a guide wire, typically a J-tipped guide wire, with the tip of the guide wire as the leading edge in advancement. The catheter and wire combination is advanced to the aortic root, where the guide wire is removed and the catheter is attached to the hemodynamic and injection tubing. An automatic contrast power injector with an integrated hemodynamic monitoring system is used in this video, although a standard catheterization manifold may also be used if a power contrast injector is not available. The guide catheter and injection tubing are aspirated, cleared of any air bubbles. The hemostatic adapter is open to allow bleed back to further verify the absence of air bubbles or plaque within the guiding catheter, and the entire system is flushed with heparinized saline, following which the hemodynamic system is zeroed. Once zeroed, the transducer is opened and central aortic pressure is transduced from the patient. At this time, the patient is administered systemic heparin IV to achieve an activated clotting time at greater than 250 seconds, which will be maintained throughout the PCI procedure. After pressure is recorded, the tubing and catheter are filled with contrast, and the left coronary artery is selectively cannulated by both advancement or retraction and clockwise or counterclockwise torque of the catheter. Typically, the fluoroscopy detector is positioned in the LAO 20 angulation for engagement of the coronary ostia. Once the left coronary artery is cannulated, an observation of the hemodynamic pressure tracing does not demonstrate pressure damping. A small test injection of contrast may be administered to verify successful cannulation and coaxial angulation of the catheter tip to the vessel. At this point in the procedure, coronary angiography begins, the details of which are highlighted in another video tutorial. In this example, a severe stenosis of the proximal left circumflex artery is demonstrated. In this example, two 0.014-inch guide wires will be advanced down the vessel of interest. The first will be positioned in the vessel containing the stenosis that is to be treated by PCI. The second guide wire will be positioned in the side branch vessel that requires to be stented across, for example, jailed, in order to effectively treat the lesion of interest. The guide wires have floppy tips, which are atraumatic to the coronary artery. A short 30 to 45 degree bend is made on the distal 1/2 centimeter of the wire in order to provide directionality while advancing the guide wire down the coronary artery. The guide wire is introduced into the guide catheter using a wire introducer and is advanced to the end of the guide catheter. A torque device is screwed onto the guide wire to aid in advancing the wire down the coronary artery. Then, using a combined advancing and twisting motion of the torque device, the guide wire is carefully advanced down the coronary artery so that the tip of the guide wire is positioned beyond the lesion of interest in the distal segment of the vessel. The torque device and wire introducer are carefully removed, and the process is repeated to position a guide wire in the side branch vessel. Use of an angioplasty balloon catheter is demonstrated here. The balloon is on the distal end of the catheter, which has a short, approximately 10 centimeter length, monorail lumen through which the catheter is advanced over a guide wire. The balloon lumen is prepped with negative pressure, and the short monorail lumen is flushed with heparinized saline. The balloon is advanced over the guide wire into the guide catheter and to the region of the lesion under fluoroscopy. After the balloon is carefully positioned across the lesion, the balloon is inflated to approximately 8 to 10 atmospheres of pressure using an inflation device filled with contrast. The balloon is filled with contrast so that it can be visualized under fluoroscopy. After approximately 20 to 30 seconds, the balloon is deflated by applying negative pressure to the balloon lumen using the inflation device. In this example, the balloon is repositioned slightly and a second inflation is performed. The balloon is then removed over the guide wire. Use of a stent catheter is demonstrated here. The stent is mounted in a crimped form onto a deployment balloon on the distal end of the stent catheter. Similar to the balloon catheter, the stent catheter has a short, approximately 10 centimeter length, monorail lumen through which the catheter is advanced over the guide wire. Unlike angioplasty balloon catheters, stent catheter balloons routinely are not prepped with negative pressure outside of the body, as doing so may result in the stent becoming dislodged from the balloon during advancement. The stent catheter is then carefully advanced through the guide catheter, over the guide wire, and is positioned across the lesion of interest. Once the stent is in adequate position across the lesion, the stent balloon is prepped with negative pressure. Final pre-implantation positioning is verified under fluoroscopy using an injection of contrast. The stent balloon is inflated to 12 to 14 atmospheres of pressure using the inflation device. After approximately 20 to 30 seconds, the balloon is deflated using the inflation device. The stent balloon is then removed over the guide wire. An injection of contrast is then administered under fluoroscopy to verify that the stent is adequately deployed. There is no mechanical complication, such as intracoronary dissection or perforation, and that there is stable blood flow into the jailed side branch vessel. After stenting, blood flow into the jailed side branch vessel may be compromised. In this situation, a third guide wire is used to enter the side branch vessel through the open cell struts of the implanted stent in anticipation of performing balloon angioplasty through the stent struts and within the side branch vessel ostia. The process of rewiring of a jailed side branch is a delicate one and is often filled with trial and error. use of varying guide wires, etc., as the operator must be careful not to advance the wire under stent struts, which will inhibit subsequent advancement of the angioplasty balloon. In this case, a guide wire with a hydrophilic tip is used to successfully cross the stent struts and enter the jailed side branch vessel. Once in adequate position distally, the original guide wire in the side branch vessel is removed. A balloon catheter with a non-compliant balloon is advanced over the guide wire in the side branch vessel and is carefully positioned under fluoroscopy across the side branch ostium and through the struts of the implanted stent. Balloon angioplasty is performed at high pressure, approximately 15 to 20 atmospheres, across the jailed side branch ostia, effectively dilating the open cell structure of the implanted stent in that segment. It is common practice to perform a post-dilation angioplasty of the implanted stent using a non-compliant angioplasty balloon inflated to high pressure, 18 to 22 atmospheres, that is either the same or slightly larger, such as 0.25 to 0.5 millimeters larger in diameter to the implanted stent. At times, an even larger post-dilation balloon needs to be used on a segment of the stent to accommodate the presence of vessel mismatch, such as widely different vessel diameters across the stented segment. Also, if post-dilation is to be performed across the jailed side branch, performance of simultaneous kissing balloon angioplasty, where balloons are positioned both in the parent vessel and across the ostia of the jailed side branch vessel, and simultaneously inflated. Once the PCI procedure is complete and an optimal result is obtained, the guide wires are removed and completion coronary angiography is performed. After the study is complete, the vascular sheath can either be removed in the catheterization laboratory before the patient exits, or in a designated post-procedure area where hemodynamic monitoring can be performed during sheath removal. During sheath removal, it is important to monitor the patient's vital signs closely, as vasovagal reactions manifesting as hypotension and/or bradycardia may occur. If hypotension is observed during sheath removal, this can typically be remedied by small boluses of IV fluid. If bradycardia is observed during sheath removal, this can typically be remedied by small doses of IV atropine. Once the patient is felt safe for transfer, he or she is attached to a hemodynamic monitor and transported to the appropriate post-procedure recovery area. Typically, vascular sheaths are removed and hemostasis is achieved with manual compression. Although a variety of vascular closure devices are available for use, none have proven superior to manual compression with regard to preventing bleeding complications post-procedure. In this video, sheath removal with manual compression is demonstrated. Prior to sheath removal, the area is cleaned with a sterile cleaning solution. The area immediately above the sheath skin entry site is palpated to feel for the femoral artery. While holding pressure on the femoral artery above the sheath at the approximate area of arterial entry, the sheath is removed. The area is allowed to back bleed for 1 or 2 beats, and then firm and steady manual compression is held. Underneath the skin, the artery is being manually compressed up against the femoral head, which provides a solid surface on which to assist in manual hemostasis. Care must be taken, however, not to hold such firm pressure that the distal pulses are not detectable, as doing so increases the risks of lower extremity vascular complications such as thrombosis. By rule, the duration of manual pressure is 2 minutes per sheath French size. So, for a 5 French sheath, approximately 10 minutes of manual pressure is held before checking for adequate hemostasis. If bleeding is still observed after the allotted time, additional pressure should be held until hemostasis is fully achieved.
So it was percutaneous intervention, most important procedure, mini-invasive procedure for the treatment of ischemic heart disease. In May, we will have another lecture where we will briefly review all vascular pathology for user knowledge. And I told for you, I think that's all for today. I wish you a good day. Goodbye, my friend.
Thank you, Doctor. To you too.
Thank you, Doctor.
Bye.